Hey folks, in case you're wondering, we are aware that it's past the hour when we're supposed to start, but the chair of the session is not here. As the president of this esteemed organization, I suppose he has the prerogative to come whenever he wants, but he is in another session that was going right up until now, and we shall start as soon as we see him or without him in a moment or two.
Good afternoon, everyone. Thank you for being here in this plenary session where we're going to discuss on the Lancet Commission on the definition of clinical obesity. And this will be more focused to metabolic and bariatric surgery, our field. We have all the participants here, Francesco Rubino, David Cummings, and Phil Showers. We were commissioners. We were part of the Lancet Commission. And the last speaker, Dr. Ackerman, who is an endocrinologist, she was not involved in the Lancet Commission, and she'll give the medical side of how the new definitions on clinical obesity may add up to our practice every day. So without further ado, I'll start with my presentation. I'm the first one. I need the slides. Los slides, por favor. My topic is to present from stagnation to expansion, how our current diagnostic framework keeps surgical volumes at 1%. We have a problem. We have an excellent product that don't sell. And there might be a reason behind this. And we need to try to dig down and find the reasons and the solutions. Those are my disclosures related to this presentation. And the main one is that I was deeply involved in the Lancet Commission for the past years. And this is the first disclaimer. The Lancet Commission is not a guideline to treatment. It's a diagnostic framework. So please, you sitting here, open your head and listen to all the speakers that we are proposing a diagnosis of obesity and not how to manage directly with drug A, surgery C, obesity. So please pay attention. This is the Venice Declaration that we It's a if so global statement published back on April this year, where we state that yes, obesity is a complex chronic disease and must be recognized across a spectrum. Obesity is a spectrum from preclinical to clinical obesity. We go in further details later. And we need to avoid diagnostic and therapeutic inertia because we need to show patients, healthcare providers, policymakers, public health experts that we need to prioritize treatment to those who need most. We need to move from corpulence, from a size, to a disease, to biology, to avoid the stigmatization and prejudice against obesity and all of its complications. And finally, we need a global access to multimodal obesity care. This is why we changed the name of IFSO. We need other therapies involved for the best outcomes of our patients. This is a scale of all people living in obesity in the world. Metabolic surgery is 1 to 3% of the eligible patients, and pharmacotherapy is less than 8%. So the bottom line is we're treating nobody actually. We know that metabolic and bariatric surgery is very powerful. We have glucocentric outcomes. We have sustained weight loss over 20, 30 years. We have good outcomes over medical treatment on hypertension, on kidney disease, on liver disease, and even on mortality. But we're still safe, even the volume is going up, so the complications and mortality is going down. However, we do not operate again who really needs. So the penetrance of surgery has been very low, despite of all evidence we've been generating for the past years. We have several RCTs on the field. We have a non-RCT match pair called the SOS study with long-term outcomes. However, we're still treating nobody. And why exactly? Because first, there are clear signs that obesity is not considered a disease. First, I just described, we underutilize all the evidence-based options. Second, there's a myopia of prevention strategies and treatment strategies. It's all mixed in the same bucket. We have widespread bias and stigma. And finally, we have huge problem with insurance coverage because we apply a lifestyle rationale to a disease. We blame the patient. The person does not eat well. The person does not move. Move more, eat less, won't solve the problem of obesity at all. And this is a very interesting slide. Look at the people. This is a discontinuation of GLP-1 receptor analogs after 2 years. So look at this graph. In yellow, the discontinuation of drugs in people with diabetes is lower than those without diabetes. And there's one reason behind this, maybe unconscious, because obesity is not a disease, so people just don't care. But if they have diabetes, which is a disease, because they have signs, symptoms, and complications, they discontinue in a lower rate than if they have obesity only. So this is a clear sign that obesity has not been treated as a disease. And the current framing of obesity is a harbinger of other disease. So we have mechanisms of adipose tissue expansions, a physical phenotype, we have pathophysiology, and we still relate to other diseases to call obesity a disease. So we need mental health issues, we need depression, we need diabetes, we need etc. Every disease that adds on obesity qualifies obesity as a disease. And this is not happening in other diseases. I don't need obesity to make a diagnosis of diabetes. Why vice versa is the right thing? Because the current treatment of obesity has prophylactic intent, regardless of the clinical severity. So regardless is if a person have a BMI of 37 and got nothing, because his or her daily life is not undisturbed, is still qualified for treatment because we still rely on comorbidities, not on a disease itself. So for a patient's perspective, if I would try to treat a risk, what goes into their mind? Oh, let me think, maybe I don't need really. I'll try another diet. Surgery is too risky, despite less than 1% of mortality and 2-3% of major complications. And where the shoes of a payer's perspective and a policymaker. Surgery is too expensive, it's costly. Medications are expensive. There's no return on investment. There are drugs for cancer, and to be clear, I'm not against oncology and cancer, but there are drugs that adds up 6 months of life in a person with cancer, and they're covered. And it's wonderful to cover a drug for a patient. However, when we think about obesity, the policymaker and the payer think about the return of investment. This should not be applicable in health. And then the payers think that they may have other priorities, maybe next year. So let's first do a mandatory weight loss before sending you to surgery. So, because it's not a lack of willpower. So, what disease that demands treating the disease to treat the disease? Obesity. So we need to lose weight, and then you are a candidate of surgery. So if you go to your eye doctor with myopia, the doctor will say, please squeeze your eyes. When you squeeze your eyes for more than 2 days, come back and I'll give you a glass, a prescription of glass. This would never happen in ophthalmology, but it happens with obesity. Because there's a guilt of the person with obesity. There's a huge scientific blindness. Nobody cares about this. We've been producing this data forever. Weight loss, diabetes, hypertension, kidney outcomes, nobody cares. IFSO and SMBS were very smart. We updated the guidelines. We're very smart, sharp federation and society. However, 95% of the PCPs, the primary care physicians, were not aware of the guidelines. So why the hell I need a guideline if nobody reads it? So this is another thing that we have to change. And nothing changes if nothing changes. So BMI buckets, classes of obesity, class 1, class 2. Look, it's not a diagnosis, it's a class. It doesn't tell the story. If this excess adiposity causes something, if this excess adiposity, where is the fat mass distribution? So at the end of the day, it's totally different than organ and tissue dysfunction that can cause functional limitation. So how do we at the Lancet Commission do the framework for diagnosis? So first, we confirm excess adiposity. Excess adiposity means obesity, period. We can use still BMI, so BMI is over 30 plus one of the anthropometric parameters, waist circumference, waist to height circumference, or waist to hip circumference, will tell us that yes, we have excess adiposity, obesity. Or two anthropometric parameters, waist circumference or plus waist to hip ratio or waist to height ratio. So those two parameters over the threshold, it's in the paper. I won't go into details now for the sake of time. So two parameters without BMI, excess adiposity. BMI plus 1, excess adiposity. And the Commission pragmatically assumed that BMI is over 40, they made the diagnosis of excess adiposity. So we came with the definition of the spectrum of obesity. We have preclinical obesity, that means persons with excess adiposity without any impairment of tissue and organs and no interference in their daily life activities, and clinical obesity, person with excess adiposity with signs and symptoms of obesity. They are described here. We have 18 signs and symptoms of obesity for adults and 13 signs and symptoms of obesity for adolescents, all based on a clinical, pathophysiological, and health impact rationale. So this didn't come out of the blue. The 56 experts didn't sit on the table and say, well, we're going to come with those signs and symptoms. No, there was tons of discussions, and this is 18 signs and symptoms in adults. They are all evidence-based. So this is the framework for diagnosis. And what changes in the care? If I have clinical obesity, the care is different. We have therapeutic intent. It's not prophylactic anymore because the disease is a functional impairment or an impairment of daily life activities at the present moment now. So the aim is to put clinical obesity into remission, putting the disease into remission finally. So we need to prioritize those individuals with clinical obesity. The difference in preclinical obesity is first, we aim for a risk reduction. So weight loss is the mean to decrease the risk long term. And we can use preventive and prophylactic intent. So this applies to preclinical obesity. And at an individual level, what changes is that people with a low risk, they will undergo screening and monitoring over time. And those with high risk may be treated with surgery or may be treated with the medical agents. The difference between this scope of care is that we prioritize those with disease. We don't treat people that do not have a disease at the moment. And the acceptance of the risk of an illness at the present moment is much higher. I'll give an example. This is a leak of a subtotal gastrectomy, very similar to a gastric bypass. So what the referral physician, the family, the patient would say, oh, okay, I will need to undergo another operation. But it was cancer, I need to treat it. How many of you already heard when a gastric bypass leaks that, wow, it leaked, why you underwent surgery? It's too risky. Why you did not try again the moonwalker diet or the shower diet or whatever diet available? This is what we hear every time. How does this change surgical indication? It's clear that traditional BMI-based eligibility is not sufficient anymore. So we need to be based on organ dysfunction linked to excess adiposity. Remember, excess adiposity, it's obesity, and then we had the spectrum of preclinical and clinical obesity. So if a person has excess adiposity and signs and symptoms, hence clinical obesity, heart failure, fatty liver disease, respiratory issues, indication should be done. Second, functional limitations in daily life activities like mobility restrictions, chronic joint pain, etc. Severe quality of life impairment due to obesity. People cannot play soccer or volleyball with their kids. It limits their lives. And the early interventions are recommended to prevent irreversible damage. How do we measure the outcomes beyond weight loss? So weight loss is a way to achieve those outcomes. So how can we measure? First, of course, improvement of obesity-induced related organ dysfunction, a restoration of physical mobility and the disability, reduce the need for obesity-related medical treatments. So we don't need CPAP, we don't need mobility aids. This is one of the criteria of success in treating clinical obesity. And finally, enhancing quality of life, including mental and social well-being. It changes the way we see recurrent weight gain as well. So recurrent weight gain without any organ dysfunction or any functional impairment may not require treatment. Why should I treat people who regain weight and has no problem at all? I have friends who underwent surgery and 20 years later they had a recurrent weight gain and they run a marathon with me. Should they deserve treatment? Do they need treatment? Not at all. And the new Lancet Commission definition shifts the focus from weight by itself and gets back to real disease. So we need to move out from this BMI-centered thing to a disease-based thing as all chronic diseases. I'm a marathon runner, I'm persistent, so we make a lot of efforts to increase access to surgery. So first, we avoid obesity stigma because this historically delays the access to surgery because we shift the focus from body size to biology. We ensure equitable treatment access regardless of the size of the person. We need to educate and train healthcare providers to eliminate weight bias in decision-making, recognizing obesity as a medical condition and not a personal failure. So, if we recognize as a disease with silent symptoms, as all chronic diseases we may think, diabetes is an example. It has pathophysiology, signs and symptoms. They eat too much, they urinate too much, they have complications, micro and macrovascular. So why not obesity? So the insurance approval should be based on organ dysfunction and not BMI. A person with BMI of 38 plus migraine should be operated. So this opens the window for insurers or payers to say, why? This is prophylactic because maybe he will develop cancer in 20 years. So prophylaxis does not warrant investment in the treatment. And we need early surgical interventions as a disease-modified treatment and integrate bariatric surgery in the standard of care of obesity treatment. So finally, what changes in our practice? First, we decrease obesity and metabolic surgery stigmatization, which is very common. Second, we prioritize persons to treatment not based on BMI only, but the need to improve their health. Then we measure and report remission of clinical obesity. If a psychiatrist gives antidepressants to a person with depression and the signs and symptoms remit, the psychiatrist put depression into remission. Why not apply this to obesity? And then we can inform the policymakers, the public and private patients of predictability who should be prioritized to metabolic and bariatric surgery. This will generate a higher demand for surgery. This is unquestionable. Please read this paper. It's a long paper. It's available at the Lancet website. It's free to download. And we just published, I think 3 weeks ago, an obesity surgery for all our members of IFSO. It's, of course, free to access and download, from BMI to disease diagnosis. It's what exactly I approach in this presentation, how those definitions will change the way we see metabolic and bariatric surgery in the management of clinical obesity. Thank you very much. The next speaker he doesn't need any introduction besides being a good friend for the past 25 years, is Francesco Rubino. He was the chair of the Lancet Commission, and he'll show us another aspect of how our definitions may change the current status of MBS. Please, Francesco.
So, Ricardo, Phil and I had decided I was going to introduce Francesco. Thank you for doing it. But Francesco, a visionary leader for many years in this field, was unquestionably the guy who did the heavy lifting among the 58 of us who worked those many years in this commission. And many of you may not know that not long ago he was knighted in his country, so it's my honor to introduce Sir Francesco.
Well, thank you very much. Thank you. Thank you very much. Thank you, Ricardo, for introducing this topic. These are my disclosure. I would like to start with the reason why we think surgery is not very appealing, and then maybe see how this new definition can realign surgery of obesity with the rest of surgery. Normally, surgical interventions are reserved for advanced, symptomatic, or treatment-resistant stages of diseases that are recognized as being diseases, not simply as risk factors as preventative therapies. Prophylactic surgery is used very rarely, in rare circumstances, and typically controversially. So you can see that surgery normally targets illness. There are many examples of that, from coronary artery bypass, cancer surgery, parathyroidectomy, splenectomy, colectomy, you name them. When you look at bariatric surgery, as we say that many times, bariatric surgery or weight loss surgery has been designed to reduce risk associated with obesity. In the first place, obesity is seen and conceived as a risk factor, and then we use BMI, which is a measure of risk, and then we use weight loss as an outcome measure, which is a measure of risk reduction. So everything revolves around risk. It conveys the message that this surgery is indeed used prophylactically, not as a disease treatment. So perhaps it's not surprising that we don't operate more than 1% of people, no matter how safe, no matter how effective we show our interventions are. So some people say, well, we're starting to see similar problems also in access to drugs. Why don't we call obesity a disease? We call it a day, we change the label, and everybody will understand that obesity has to be taken seriously. Not so easy. Not so easy for many reasons. The first one is because we never framed obesity as a disease, and therefore, it's not like you change the label and everything goes in place where you would like to. Normally, approaches to diseases in medicine are quite obviously focused on these different steps. The first and most important one is the definition of the disease. The definition is what the disease looks like. We know exactly how diabetes looks like. We know what Parkinson looks like. We know what Crohn's disease looks like, and so on and so forth. What does obesity look like as a disease? What are the symptoms? What are the signs of obesity, other than corpulence in itself, which we know doesn't correlate with health or illness? So we don't have a definition of obesity as a disease. As a result, we don't have a diagnosis of obesity. Normally, diagnosis is focused on, signs and symptoms of a disease. If we never define them, how we can have a diagnosis? In fact, we have classification. Ricardo just mentioned that we only have this BMI-based classification that doesn't tell much about health or illness. Now, staging normally in medicine is something that is applied to a single disease. You stage the advancement, how much advanced is that disease. Now, if you don't have a definition, our staging also suffers from that problem. So we do have some risk scoring, some staging systems in obesity. We call staging system them inappropriately because it's not exactly what staging means in medicine. Staging applies to a disease. We have very many management frameworks. We have the NIH 1999 guidelines for bariatric surgery, which typically put together a number of comorbidities around obesity to make the case for surgery or the trigger for surgery. And then we have other frameworks more recently, from the Edmonton score to the King's score, the more recent EASO score. All those frameworks, all those things are excellent, but they had a different purpose. They had the purpose of informing management and creating some sort of algorithm for management. But they do not define, let alone diagnose, disease. In fact, that's what obesity is lacking. It's lacking a definition and diagnosis of disease. Well, why that is problematic? Why is it that people didn't do this before? Why they forgot to define the disease in obesity? Obesity has been around for as much as mankind has been around. And yet, we haven't seen a definition of disease. The reason is that doctors in the past and also in the present have seen that obesity looks different from a subject to another, from one another. It's not always the same thing. Hippocrates and Galen said, well, obesity could actually be a disease for some, but not for all. In fact, there are some people where obesity is relatively a normal condition. It's just a different condition, but it's a normal condition. And this has been said by Galen and others, and all throughout history. It's only in the 20th century that we framed obesity only exclusively as a risk factor. But doctors have been always comfortable with the fact that there was this not uniform way of approaching obesity. They were comfortable with the fact that it could be a risk factor, it could be a disease as well. So we don't have a definition around corpulence focusing on excess body size, because in fact obesity, which means excess body size, manifests clinically as a spectrum. That is settled. That is set in stone. We know it is clinically a spectrum. In fact, we've seen this, Hippocrates and Galen saw this many years ago. We see this still today. We have people like Maria who have no organ dysfunctions. They can go about their lives. They don't like to be told they have a disease, and probably they are right. But then we have people like Jack, who has all these signs and symptoms of a disease. He has organs that don't work anymore. His life is affected. Why this person should not be recognized as having a disease? And the fact that he should be recognized as having a disease doesn't mean everybody else with obesity should, because if we do that, then we can blur the picture, and that doesn't help. So the Lancet Commission has focused, and this is very important, the Lancet Commission has focused on filling exactly that gap, creating a definition and a diagnosis of obesity as a disease. We did not even try to develop a management framework. We just didn't try. Those are steps that will come later on. The first step is to make a diagnosis. That was the focus of the Lancet Commission. Now, if you think that is not important, Dr. Horton, the Lancet editor, chief editor, said, the definition of clinical obesity is a sharp before and after moment in the history, not just of obesity, of medicine. And that underscores, he did also that in an editorial, he underscored the fact that the diagnosis of a disease, which is so important, was lacking in obesity, and in fact, that's actually surprising. It's almost stunning that we don't have a diagnosis for disease, and we have been dealing with this problem so long, and now at epidemic levels. Now, there is no philosophy about what a disease is, okay? So people say, oh, the disease cannot be defined. They are defined. Diseases are biological processes that affect your organs, one or more. If your organs don't work normally, you will show signs or symptoms of impairment of those organs. If your heart doesn't work, you're going to have palpitation, or you're going to have shortness of breath, and so on and so forth. There is no disease that doesn't have a corresponding illness. In fact, diseases are recognized first and foremost because of the illness they cause. Diabetes has been recognized for thousands of years because consistently everybody who went making too much urine, diabino in Greek means passing urine. Everybody who had that problem had the same evolution in time, the same prognosis. So they could label that thing disease because it looked like one. But when obesity was looking a bit of everything, there wasn't such urge to univocally define obesity as a disease. So the disease definition is typically based on clinical manifestations and the evolution of those clinical manifestations, the prognosis, the natural history of those. That's what defines Parkinson, diabetes, et cetera, et cetera. The diagnosis can be based on biomarkers, but only when those biomarkers predict the development of those clinical manifestations or the prognosis. Very often you don't have biomarkers because it's difficult, and those are discovered after. You don't discover the biomarkers before you discover what the disease looks like. It doesn't happen in no other places of medicine. So that's why we define clinical obesity. Clinical obesity means you have excess adiposity, but not only you have excess adiposity and a risk related to it, you might be at risk of getting diabetes and cancer, etc., but your excess adiposity has already impaired organs. So there will be resulting signs and symptoms. And preclinical obesity is just the presence of excess adiposity without organ impairment. So people still maintain those things. Even the people who criticized us for calling preclinical obesity have yet to provide evidence that it does not exist. Nobody could say it does not exist. We see this every day, all of us, our families, our grandma, our friends, ourselves sometimes. We know that we are doing relatively well. Yes, we might be at risk. We have obesity, but we are doing well. Our organs work. So these are the signs and symptoms. I invite you to read the papers for a list of all of them. Those can be detected by sometimes as easily as just taking a medical history and making a physical exam, and sometimes by obviously requiring lab tests, as you would do in medicine for everything else. So why does this matter? Because defining disease doesn't draw the line between what you treat and what you don't treat at all, okay? Defining disease and defining preclinical conditions define targets for different type of interventions. You want to know who has preclinical obesity because you want to treat risk. Doctors treat risk, not just diseases, but they treat it differently than the way they treat disease. And if we don't know which one is which, guess what? We will end up doing exactly what we did with obesity for all these decades. We overtreat some, we undertreat most, and that's the story. So, of course, if you understand what targets are, and then what you need to do in those targets, then the measure of outcomes for your interventions will be different. Weight loss is great, maybe not so much great, but it's good as a measure of risk reduction. It's a surrogate. But weight loss is not enough, doesn't tell you anything if you have clinical obesity. What if you lose 30% of your excess weight, of your body weight, and you still have your heart failure, your lungs are not working, et cetera, et cetera? I'm afraid that that's not success, or at least not full success, and so on and so forth. Now, this framework this publication has had a massive impact in media. Media coverage has been by far bigger than any other Lancet Commission before. That's what they told us from the Lancet. And there are reasons for that. But one of the things I want to highlight is that normally you get a lot of pushback when you suggest even remotely that obesity could be a disease. That's public, there's a lot of opinions. Nobody argued that clinical obesity is an objective disease state. And I think that is something that was not to be taken for granted. So if we have achieved something, I think that's convincing the public, even the media, but the public and many more. The Lancet Commission has been considered one of the most influential events in health. And if there has been a little bit of confusion and criticism, strangely, it is mostly from our own ranks. We have some colleagues who have not fully understood what we try to say, or they may rightly have some confusion. This is a new thing. It's normal to have some confusion on new concepts, entirely new concepts. We regret, however, that somebody has spread some misinformation. That's unfortunately what it is. It's misinformation. Some people say that the Lancet Commission is dangerous because we have said that preclinical obesity can be approached with a watchful wait. Now, I don't know where they took, I'm just copy-pasting from where these things have been said, and then I'll copy-paste what the Lancet Commission actually said. There is no place in the report that uses watchful weight, in any place, in any infographics, in any text, etc. What the Commission said is preclinical obesity is a state of risk. And depending on the individual level of risk, you may need interventions that are aimed at risk reduction, and those could include pharmacotherapy or even surgery. Guess what? How we go from that to say that we are recommending only for watchful weight? So that's misleading. The other claim was that the Commission said don't treat obesity in people with type 2 diabetes. And here, copy-pasting from the table 1, number 27th consensus statement, the Commission says, because of the interaction between obesity and diabetes, which was very well known, it doesn't matter if it's preclinical or clinical, obesity must be aggressively treated. So this is what the Commission said, and the other one is the misinformation that has been put around. I think it's safe to say that this is inaccurate, and I think we need to keep the debate in obesity as accurate as we can, otherwise we generate a lot of confusion. But that said, even if there are some misinformation going around, it is okay, and it's normal to have discussion and debate. We anticipated that this is not going to be necessary, something that everybody agrees with. It took 4 years for us to develop, and we know better than anybody else, because we've been there, that it's not easy to accept this concept. It was a process. And so we should expect our peers to have the same time to digest and accept, ultimately, these things. So there's some reasonable questions. One of them is why the Commission didn't come up with a definition of obesity blanket as a disease. Why you didn't do that? Well, we didn't do that for many reasons. First of all, biologically and clinically it's a spectrum, so you can't just give a blanket definition. But also because that definition, blanket definition, would not serve anyone. If you have obesity and you have a risk, but you don't have a yet disease, there's a type of intervention for you that is certainly different than those you would use for somebody who has already has fallen into the hole of what you would, metaphorically call it disease. And so the tragedy would be to use prophylactic intervention for people with disease, but equally disease treatment for people who don't have disease yet. So having a framework that reflects the reality of a spectrum and tell us who is fundamentally important. And that's the most important reason why obesity could not define blanket a disease. That would be a narrative that serves maybe other purposes, but certainly not medicine. The second thing is why diabetes is not a diagnostic criterion. Everybody asks about this. Why diabetes? We're used about diabetes for decades being the principal trigger for surgery or other indications to treating obesity. And so people say, well, this is odd. And I understand that. And we do understand that. But diabetes, when it happens, affects other organs. And also, when it affects the same organs as obesity, it affects those organs in different ways. The prognosis of diabetes is different. A person with obesity without diabetes will never develop retinopathy. You don't have to worry about retinopathy unless there is diabetes. Certain type of neuropathies only happens with diabetes. The prognosis of diabetes is so different that those of you who do clinical trials here know too well that the first exclusion criteria for those trials is diabetes, because the prognosis in response to treatment, it takes a life of its own because there is another disease there. So here is the thing. Diagnosis is different than management frameworks. What we were used to when we put diabetes in there is a management framework. And that is okay. There is okay to put diabetes because you put also depression. You can put everything else that gives you the bigger picture. But diagnosis is like a fishing rod. It catches only one fish. And it's designed to catch only one fish. In other words, to catch only one disease. So you have to be very, very accurate in saying, is this a disease by itself, independent on other diseases? When you do a management framework, it's perfect, like NICE and all the other frameworks, the ASU frameworks, you can put other things. But just because those two things are apples and oranges, and we have to keep them separate. So why preclinical obesity, to conclude? A lot of people are concerned about preclinical obesity. It exists, so we cannot deny it, number one. Second, because it exists, it's important to recognize it. And third, we do this in medicine all the time. There is HIV infection and there is AIDS. There is hypercholesterolemia and heart disease, prediabetes and diabetes, and gas and multiple myeloma. Perhaps the most obvious difference that we make is polyp and colon cancer. We know cell proliferation is a spectrum. At some point there's a cancer, at some point there's a polyp. Nobody is worried that defining polyp different than cancer is an incentive to not treat polyps when they are high risk and they have to be removed. But we don't want to treat polyp and cancer exactly in the same way. And so that's why there is preclinical and clinical obesity. So to translate in our field, obesity could be preclinical. At that point, if it's low risk, there are elements that will have to be defined. We will need a new risk scoring system for preclinical specifically, but there will be a way to identify people with low risk preclinical. There you may go with lifestyle intervention and maybe escalate intervention if needed, but you can start with lifestyle interventions. Why not? It's not sacrilegious to say that in 2025. But if somebody has a high risk preclinical, it doesn't matter if it's clinical, you will have to intensify the intervention because the risk is higher, and you can justify a higher cost, a higher risk from the intervention, so you can justify pharmacotherapy and surgery. And to conclude, we're already doing clinical obesity, surgical treatment of clinical obesity. These are 4, including my own practice, but 4 practices around the world, Ricardo's, François Patou, and Hospital de Mar in Barcelona. You can see that most of our patients, as you would predict, have a clinical obesity, 67, 70 to 80% roughly. Now, in the general population is the flip of this coin. So you're going to have probably 70% preclinical and vice versa. But in obesity, with surgery, are doing that. And guess what? Nobody knows that we have been operating on a disease state for so long. People still think we do weight loss surgery. So changing that, and then I'm going to conclude, the definition of clinical obesity will serve everybody, but will serve also patients and the surgeons who are delivering this incredibly effective treatment, because for the first time, we have a way to describe when and why surgery for clinical obesity looks exactly the same as any other type of surgery. It aligns with the very concept of surgery delivered for a ongoing disease state. And so this is the final slide to say, at least it might be my vision, that we'll see in the future obesity becoming more and more like other areas of medicine. There will be interventions to reduce risk from making a clinical obesity happen in the first place. So addressing preclinical obesity will be important, and will be important to understand what is the best way to do it. It could be pharmacotherapy, it could be lifestyle intervention, and sometimes surgery. But surgery will be increasingly, and finally, I would say, after many years of misaligning surgery, focusing on the right target for a surgical intervention, which is disease, ongoing disease, in that case, clinical obesity. And we will be able to justify combination therapies in people with ongoing disease and severe disease, because the cost effectiveness of adding very expensive treatments together might not work so much for a preclinical condition, but it might work for a disease. Thank you very much.
Our next speaker is Dr. David Cummings, very well known to this audience. He's professor of medicine in the Division of Endocrinology at the University of Washington in Seattle. He was also a very prominent and busy member of the Lancet Commission. And he'll be talking about the commission statements from the payers' perspective, convincing payers and policymakers how the new definitions translate into economic and public health gains.
Thank you, Phil. Hi, everybody. So that was the long title that the organization gave me. I took this to mean that I'm supposed to talk about how our new definition of obesity might affect policy, and that will be my challenge today. Those are my disclosures. I'm on the following scientific advisory boards. So the commission was faced with the question of what is obesity? And we tried to face the problem that BMI, used in the past as the sole definer of obesity, if used as a standalone criterion, very often either overdiagnoses or underdiagnoses obesity, as Francesco just outlined. So we worked as a commission of what ended up being 58 people, started out as more, for close to 4 years, very hard, to come up with something instead. And we wrote a really long paper. The manuscript was 150 pages long. In the journal, it's close to 50. And if I were to distill it down to one sentence, it would be as follows. The Commission recommends changing the definition of obesity from simply being relatively heavy for one's height to being ill from having too much body fat. And we hope that this offers a meaningful and clinical and ethical alternative to help optimize allocations of limited resources to prevent and treat obesity. Now, in terms of how this might affect policy, I'm just going to focus on the one area where I think we might have the biggest impact in policy, and it's my sincere hope that we do. That is in how to allocate who should get these great new drugs, incretin-based hormones. So as has been very well pointed out in this meeting, the new incretin-based drugs are terrific. This is just one figure showing that from the SURMOUNT extension trial published earlier this year in New England Journal. It shows you that tirzepatide maintains a 23% weight loss out to at least 3 years with no evidence of waning. In this study, everybody started with prediabetes, and at the end of the study, 95% of them have converted to normal glycemia, and if they had frank diabetes, that gets a lot better too. Beyond just their impacts on obesity and diabetes for which they were designed, these new incretin meds have many other benefits on harder outcomes that have been shown in a whole series of New England Journal level papers in the last year or so. They've been shown to reduce major adverse kidney events, major adverse liver events, sleep apnea by a stunning 50% apnea-hypopnea index reduction, clinically significant osteoarthritis, congestive heart failure, and for both semaglutide and about to be announced next week, tirzepatide, reduce cardiovascular events. So they're terrific drugs. No surprise, their usage is just skyrocketing. So here's a graph of incretin-based medications over the past few years. They are increasing by double-digit percentages every quarter. They're up 900% between 2019 and 23, and they are the fastest growing drug class in history. The trouble is, they're crazy expensive. So how expensive is that? Well, I'm just going to give you absolute costs initially, and I'm going to quote my country's numbers. So in our country, it costs to take either semaglutide or tirzepatide somewhere between $900 and $1,350 a month. So to put that in perspective, metabolic bariatric surgery in our country costs about $17,000 to $26,000, and for most people, that's a one-time deal. The bottom line is that in considerably less than 2 years on taking these medicines, you could have bought yourself a gastric bypass, and for most people, that would fix you for life. Now, those are the absolute costs. What about costs per benefit gained, usually expressed as the cost per quality adjusted life year, the cost of a theoretical year of perfect life? So metabolic surgery costs about $10,000 to $25,000 per quali. That's about 5 to 10 times cheaper than the usual societally defined metric for what's considered affordable health care. Contrast that to tirzepatide or semaglutide, which cost a stunning $1.1 million per quali, about 10 times higher than what we usually consider affordable health care for which insurance companies will pay. I'm stunned that any insurance company covers this stuff. I'm delighted they do, but it's no surprise it's waning. This leads to an expression that I think Ricardo coined: metabolic surgery ain't sexy anymore, but it's cheap. I love that expression because we used to think that the cost of your operations was a barrier, but by comparison to these new meds, they're dirt cheap. Semaglutide is already the #1 drug in the United States by drug costs. And this leads to significant access problems. People who want the drug and can't get it due to a combination of supply chain problems that just continue to dog us many years out, global shortages, and patchy insurance coverage, undoubtedly made patchy because of the extreme cost. This is a list just recently published of insurance companies that have either recently stopped paying for the drugs or greatly restricted their access. #1, the Veterans Administration, the largest healthcare system in the country. We used to have both drugs. I was the #1 prescriber of semaglutide in the nation in the VA system for a year. And then they said, sorry, it's too expensive, and they stopped both of them. So we don't have either one of them at all. Also, restricted their access comes from big companies like Blue Cross Blue Shield, Kaiser, Alina, and so on. The list is long of insurance companies that are starting to pull back on how easily they'll cover these medicines because they can't afford to cover them for everybody who wants them. This helps contribute to these stunning statistics that I've seen several times in this meeting. The percentage of people who start an incretin medicine who are still on it at 1 and 2 years. In fact, at 1 year, of those who started it, more than 60% have already stopped. By 2 years, it's 83%. Is that because, well, they used it to lose weight and then they could maintain the weight loss by themselves? No. Lots of studies have shown that when you stop the drugs, all the benefit returns. SURMOUNT-4 is a good example. They put people on tirzepatide. They lost the usual 21% body weight, then randomized to continue on tirzepatide or get placebo in a blinded way. The folks lucky enough to stay on tirzepatide continue to lose weight even more. The guys unlucky enough to get put onto placebo bounced right back. This and other studies show by 1 year off the meds, most of the weight you lost will be back. All the benefits on diabetes, blood pressure, lipids will be gone. The drugs don't work if you don't take them. So this leads to some hard, practical truths about our great new incretin meds. A recent publication in JAMA Cardiology estimates that more than 50% of adult Americans qualify for these medicines by their original criteria. Those were based on BMI only. So what would it cost us to actually treat everybody who qualifies? I did a calculation for that using a middling dose of the estimated cost range, and it's about 2.4 trillion American dollars per year. Now that number's too big to get your head around, so let me put it in perspective. $2.5 to $4 trillion is about 3 times what we spend on military and defense, and the USA spends as much more on military and defense as the next top 10 countries in the world combined. It's about half of what we spend for all healthcare of everything, and it's about 1/3 of our notoriously terrible national debt. It's a completely unbearable price. So we need a triaging system to decide who is most applicable to get these expensive drugs that we can't afford giving to everybody who wants them. It is my sincere hope that our new definition of clinical obesity offered by the Lancet Commission offers an evidence-based triaging tool to help allocate this limited resource to people most in need. Now, it used to be that the criterion for use were based on BMI. Since then, both Novo Nordisk and Lilly have changed those criteria and just said that their drugs are for people, quote, with obesity. And they don't say what that means. It would be my sincere hope that insurance companies will take advantage of this opportunity to use our definition of what obesity is so that the people most in need, most likely to extend in their lives and not just look better in a dress, get the drugs, and people less in need can get by with less expensive stuff. We hope that this will facilitate a more rational and cost-effective use of expensive obesity treatment options rather than just cheaper, lower-intensity preventative medicines for people who are less at risk of real peril now. I'll close by just saying I also hope that our formal definition of clinical obesity as a disease should help reduce weight stigma in the sense that it would take it out of the realm of a behavioral failing and put it into something, a disease like cancer or high blood pressure or whatever. Thank you very much for your attention, and that's all I have to say.
Next, we'd like to welcome to the podium Dr. Marinella Ackerman. Dr. Ackerman is an internist, and she is at the University of the Northeast in Argentina, where she is an associate professor of internal medicine. She has focused her career on obesity medicine, and she will speak about a critical internist view of overcoming medical barriers to surgical referrals.
Thank you. Good afternoon, and thanks for coming. It's an honor for me to be here. My disclosures. For decades, BMI was the useful that we use to diagnose and make decisions. And the Lancet Commission proposal is the first diagnostic proposal in many years. Like Ricardo shows us, most patients with obesity never get proper treatment. And if no change, never will change. We need to think and act differently starting now. Why internists still rely on BMI? It's a simple, fast, universal, cheap. It's in all guidelines and medical records, but misses dysfunction. Fatty liver, sleep apnea, function. Lancet Commissions close the gap. Guidelines still rely on BMI for surgical indications, but the Commission established as disease-based model for diagnosing obesity. Surgical criteria should follow the disease model. Well, this is the framework. They distinct the preclinical obesity, the excess adiposity, but without measurable disease, and clinical obesity with altered function or tissues and, or individual due to excess adiposity. The Lancet Commission, with this proposal, this is the major advance. It moves us beyond BMI. And I think that this is the more important thing in that proposal. Think of a woman with 32-year-old, BMI 33, with FIB4, with advanced liver disease, fibrosis, hypertension, ineligible by BMI only rules, but eligible under Lancet Commission definition. But this is a really good approach, but the implementation is not easy. As the author said, implementation of this recommendation, however, will carry significant costs and workforce implications for health system. This will clearly be challenging. We need education, training, and resources. This is why they add in the annexus practical tools to assessment form for clinical obesity. They put 12 topics to assessment. I will quickly pass through this. In the real world, obesity management starts and ends with BMI. This is the real world. The internist visits are short. They have another priorities. Less than 10% use obesity guidelines. Routinely, we have insurance barriers. And if we don't communicate proper, we have the risk to confound preclinical to no action. In this paper, you can see the reasons why the PCP have barriers to obesity treatment. The first reason is patient has other health concerns or conditions that are more urgent in 90% of people. Short visit, 90%, or another barriers like no insurance coverage. We have a multi-level barriers. The provider level barrier, the most important is the most the internists have little or no education, formal education on obesity. There are also stigma on consultations and the time pressure in we need to do a lot of things in only 15 minutes. How the Commission, in my opinion, brings internists closer to surgery. It gives a clear definition. Obesity means organ or functional damage, not just BMI. We move beyond BMI. It provides clinical criteria allowing us to identify patients that BMI alone would miss. It strengthens our arguments with payers to secure coverage for surgery, and it connects the criteria with surgical outcomes, A1C, NAFLD, sleep apnea, high hypertension, for example. We need more complete clinical evaluation of patients to define their health status. That Ricardo shows earlier, 18 signs or symptoms. Maybe if we can give a practical checklist for the internist, will help them to improve the utilization of that diagnosis. We all know that change in medicine takes time. Cultural change takes time. We need education and internist and surgeon collaboration. Without education and teamwork, referrals will remain BMI-driven for many years. We need cultural change as well as new definitions. Well, some proposal for internists, the first, of course, educate clinicians on the new criteria. Remember that clinicians don't read the guidelines. Use electronic records to flag patients at risk. Provide clear language to explain preclinical obesity and built-in process for surgical referral. And for surgeon and societies, promote payer coverage based on disease, not just BMI. Our goal is to use resources more effectively by providing care to those in need and avoiding overtreatment of individuals who may have an elevated BMI but no health impairment. The Lancet Commission gave us the first step. This is a big step. Now we must work together to move beyond BMI and turn barriers into bridges. Thank you very much.
Four minutes. I don't think we need. Yeah. Thank you very much, Marianela. For the sake of time, we don't have extra time available for questions. However, all those bright speakers will be out and ready to answer whatever questions you may have. Thank you very much for attending this session. And is Mufi in the room? Mufi. Mufi, we'll take a picture and the floor is yours.
All right. Okay. After this really heavy session, we thought we'd get back to some of the stuff that IFSO is really doing a great job of. And I must commend Ricardo because he's come out with many position statements whilst being the president and headed this. We thought that sleeve gastrectomy is the most commonly done procedure today across the world. But we do know that there are issues with the sleeve gastrectomy. So we thought the best option would be to optimize outcomes vis-a-vis a sleeve gastrectomy. And we discussed a lot about the terminology that we use in terms of optimizing outcomes, because there have been previous consensus before, and we thought, let's go out and do a decent job with this. So this was the entire gang of people, or culprits you can say, who got together in Mumbai just before the IFSO APC to try and go around this consensus. What we did, the team conceptualized basically between me and Ricardo, and we thought it would be a great topic to come out with a position statement on. And then we thought, how do we make an expert-based position statement? The most important thing was to get data review and research. And then we had three great guys, Mohammad Kerman Saravi, Chetan Parmar, and Yosuke Seki, who must have burnt the midnight oil and spent hours and hours, because some of the data that I'm going to show you is all the data that is relevant and present, whether there is a lack of it, or whether there is a presence of it, in terms of few things that we looked at. Then there was the expert of Delphi that we got on, Randy Levinson, and eventually we had two other members who joined us to write this publication. They were Paulina Selman and Gerhard Prager. So the aims of this position statement was very clear. We wanted to check the suboptimal clinical response post-sleeve gastrectomy, what was the relevant data there, and what were the options available for that. Recurrence of weight gain post-sleeve gastrectomy, which is a known thing, and all of us discuss it, but nobody has the real data to do that. GERD or de novo GERD post-sleeve gastrectomy, what is the data? And revisional surgery options and the timing in the era of OMMs vis-a-vis GERD and vis-a-vis suboptimal clinical response or weight regain. So we had this entire group of people. This is a busy slide, but we tried to make it a little less heavy with just surgeons, and included gastroenterologists, included physicians, endocrinologists, all part of this slide. There were 3 rounds of Delphi voting. 2 were done online after all the research and publication was concised and sent off to all the experts before they were allowed to vote. So if we look at this slide, what we actually did was we scoured the databases from the Cochrane database to the NBase to Medline to PubMed and everything that was there. We got around 3,100 publications and registries of around 180 odd. We removed, because of duplication, we removed around 380. Then the records were screened, and 712 of these records were excluded. The records were further screened for evaluation of title and abstract, and full text articles of around 214 were excluded. So reports were accessed for eligibility were 345, and eventually 131 publications were actually picked with all the relevant information that we did want for this 3 or 4 topics that we were looking at. If you look at this, these are very busy slides, but these are various publications that we went through for various topics. From suboptimal initial clinical response, these are the publications that we looked at. Then when we looked at the management of persistent or recurrent obesity-related comorbidities in terms of diabetes, hypertension, dyslipidemia, these were the publications we did look at. Now, in terms of management of persistent or de novo gastroesophageal reflux, 40 studies entries reporting management strategies for GERD after sleeve gastrectomy were identified. Now, please understand that when we looked at this data, the outcomes were heterogeneous across studies because all the patients didn't have GERD or HQRL scores, ambulatory reflux matrix, Demister scores, proton pump inhibitor status, remission or resolution rates. Interventions were eventually grouped into the following categories for qualitative synthesis where feasible. Conversion to either a Roux-en-Y gastric bypass, an OAGB, a SADI, a magnetic sphincter augmentation, a ligamenteries cardiopexy, hiatal hernia repair with or without gastropexy, were all the various things where we had some data on. LES and Strata were excluded from the analysis because they're no longer in clinical use and not recommended by the relevant societies. So when we looked at 24 studies that mentioned Roux-en-Y gastric bypass of a total of around 1,000 odd patients, what the pooled patient data actually said is that GRD quality of life 10 weighted mean change, AET of 5.9 weighted mean change, improvement in symptoms and acid exposure was suggested through the magnitude of smaller or less consistently reported for Roux-en-Y gastric bypass. So overall, a 54-point change from the baseline in the GERD quality of life questionnaire, AET mean change up to 23.3%, DMISTA score change of 93.7%, and a remission and resolution rate of almost close to 95%. So overall, RYGP conversion yielded the most consistent and substantial improvement across system and physiologic metrics with high rates of symptom control and objective reflux after a sleeve with GERD. What about the OAGB? Well, a lot of studies will, theoretical studies will say OAGB does improve. Well, if you look at the GRDHL meter scale, it was 10 points and 5.9, much, much less than what we achieved with RYGB through publications. So the improvement in symptoms and acid exposure was suggested, though the magnitude was much smaller and less consistent than the Roux-en-Y gastric bypass. What about the SADI? Well, SADI had mixed and small cohorts. We couldn't really judge what there was. The available entries were incorporated into mixed hiatal hernia repairs. Some did it, some didn't follow it. So a standalone anti-refluxist strategy of sleeve evidence still remains out there and is sparse at best. The magnetic sphincter augmentation, well, you see that the HQRL weighted mean change was 35, much more than the OAGB. Other physiological PPAR endpoints were variable reported and insufficient for pooled estimates. So this data indicates that substantial symptom improvement after magnetic sphincter augmentations were limited, but encouraging objective collaboration with further reports. What about ligamentin teres? Well, ligamentin teres shows high rates of symptom control in early follow-up, but heterogeneity and sparse physiological data precluded robust quantitative synthesis beyond descriptive reporting. Hiatal hernia repair and gastropexies, well, retrospective studies, only 28 patients, and evidence suggests symptomatic benefit in selected patients, but durability and physiological normalization was not there. So you had almost everything that there was in terms of what we did. Well, the management of metabolic outcomes. Now, once we dealt with GERD, then what about the metabolic outcomes? Well, with the OAGB, consistently improved glycemic control and blood pressure with variable but often marked improvements in lipid and sleep apnea across all the papers that recommended OAGB after a sleeve gastrectomy for metabolic outcomes. What about the Roux-en-Y gastric bypass? Well, follow-up showed durable glycemic improvement and meaningful rates of hypertension and dyslipidemia remission, although outcomes varied with cohort and baseline disease severity. The re-sleeve gastrectomy was looked at, and what some showed no hypertension remission at midterm, while others observed meaningful improvement. Collectively, re-sleeve improved metabolic parameters only in a subset of patients, but generally underperformed when it compared to the bypass variants. Now, what about the pharmacologic adjuncts after surgery? We also put in the various drugs that could be used for metabolic outcomes. Well, the endpoints of remission and improvement, baseline disease definitions, and follow-up intervals were all looked at. So for this, if you look at the things that we looked at, metabolic syndrome component remission after revisional procedures in terms of the duodenal switch or the SADI, the OAGB, the RYGB, or the re-sleeve, you realize that the SADI or the DS seem to improve metabolic outcomes the best. The OAGB slightly better than the Roux-en-Y, but not too much statistically significant, and then eventually the re-sleeve. In terms of management of recurrence of weight gain post-sleeve gastrectomy, well, the Roux-en-Y gastric bypass demonstrated consistent and durable weight loss outcomes, averaging a 24% total body weight loss, and sometimes even up to 50% excess weight loss up to 3 years, with sparse data beyond that. What about the re-sleeve gastrectomy? Meaningful short and mid-term weight reduction with notably high excess weight loss reported at 2 years in some studies. The one anastomosis gastric bypass provided substantial and significant weight loss benefits, particularly notable for high percentage total body weight loss at 3 years. The dual switch and single anastomosis, well, they showed the best kind of excess weight loss and total body weight loss as compared to the other things. Even at 5 years, SADI results showed very good. So eventually, when we put all that data and all the voting that was done by the experts, what did we asked them to vote on various statements. So in the first module was diagnostic evaluation and management of gastroesophageal reflux disease. And it had 10 statements. And most of them actually got voted. 9 out of these 10 statements achieved a high complete consensus of grade A or A+, reflecting a broader agreement amongst the experts regarding the refluxogenic nature after a sleeve gastrectomy, and that de novo GERD remained a concern with most of the experts in the meeting. The consensus was lacking regarding the role of endoscopic interventions, and only 44% believed that endoscopy had any role to play in terms of remission of GERD post a sleeve gastrectomy. When surgery was indicated, Roux-en-Y gastric bypass was unanimously recommended, a significant 100% by almost all experts. Conversion to one anastomosis gastric bypass was acknowledged to carry a significant risk of reflux, and therefore, most people said that if it was only for GERD, a Roux-en-Y was far better procedure than the OAGB. When it came to suboptimal clinical response of recurrent weight gain, there were 15 statements that we all voted on, and we reached 7 of these reaching a grade A+. Sleeve gastrectomy was specifically noted to have a higher risk of recurrence of weight gain as compared to the Roux-en-Y gastric bypass in the publications that we had, and 97% voted for that. The use of anti-obesity medications, the current ones that were just discussed, particularly liraglutide, because that's the only data we had at that point of time, and we don't have data on semaglutide or on tirzepatide, was strongly supported as a first line of treatment, though today I believe we've got the tirzepatide and the semaglutide, which might go ahead of liraglutide, but that still the consensus belief would be the first line of treatment for suboptimal clinical response or recurrence of weight gain after sleeve gastrectomy, and revisional surgery would be pushed only after failure of these drugs. Conversion procedures like the SADI-S and the BPDDS were endorsed to have far superior efficacy in achieving significant long-term weight loss after sleeve gastrectomy. However, greater nutritional risk is what the experts believe. Roux-en-Y gastric bypass remained a preferred revisional procedure, especially in patients with concurrent GERD and anatomical complications. When it came to suboptimal remission of comorbidities, well, all 5 statements in this module received a strong consensus grade A, addressing the recurrence and persistence of metabolic comorbidities such as type 2 diabetes, hypertension, dyslipidemia, and after initial remission with sleeve gastrectomy. What most people believed that there were a lot of complex pathophysiological mechanisms rather than just recurrence of weight gain that guided why someone got type 2 diabetes, dyslipidemia, or hypertension after sleeve gastrectomy. Then we didn't go into further details discussing MASH or MAFL, chronic kidney disease, and other things like OSA because there wasn't enough of data relevant and available. Today, we proudly say with the efforts, I think mainly of Ricardo and all the rest of the team, we managed to get this paper published, and it should be out for all of you all to read it at the British Journal of Surgery. There's going to be significant, I believe, improvement in what because this data was really well researched, at least currently where we stand in terms of the IFSO position statement on optimizing outcomes after sleeve gastrectomy. That was the entire team, and I thank IFSO again for sponsoring this Consensus Summit. Thank you so much for your patient listening. I think there's nobody here. Does anybody have any question? You can take one or two questions, maybe. None? All right. Thank you then.